First to present in this session is Maureen Kerrigan. Maureen is a lawyer and technical advisor for the Consortium of Medicaid and Medicare Services. Please help me to warmly welcome Maureen Kerrigan.
Good morning. So it's great to be here. Glad to. I'm here to tell you about some of the assistance that we have out there for you that can be very helpful in navigating our programs. I was telling somebody earlier, I've come to realize that one of the reasons it's so complicated is Medicare, has to serve everybody. So everybody's got little different things. So when you tell me it's complicated, I know it is, but that's why. It tries to meet the whole public, all the different needs that there might be. So Medicare, first off, let me clarify the distinction between the different programs. Medicare is for people who are age 65, and that's the great majority of our population, probably 80%. You can also get Medicare if you are determined to be disabled by the Social Security Administration. That's another reason why we're complicated, because we used to be part of the Social Security Administration. We haven't been for a long time, since President Carter, but they still have some pieces of Medicare. So you enroll in Medicare at Social Security, for example. But now you may know that Social Security doesn't necessarily qualify. You may not get it at 65, but that's part of why it was all together. Anyway, so there also, if Social Security determines you're disabled, you also can get Medicare. And that's a high level of disability to meet that requirement. And that's the other 20%. Then there are two other carve-outs. People who have end-stage renal disease, that means being on dialysis or having had a transplant, they also get Medicare without a different waiting period. And then people with ALS also get it. They just were two things that Congress carved out to provide Medicare coverage. Medicaid is a program for low income, and there's a little difference from state to state what the requirements are, because it is a federal state program. I am with a federal office. We're in the regional office in Boston, and we have 10 regional offices around the country. We cover the New England region, the 6 New England states. And for Medicaid, we have folks in my office, but really it's administered by the state. They just oversee the Medicaid. And every state comes in with a plan. There's some requirements, but then they come in with deviations they want. And this administration has been really promoting letting states have as much flexibility as they can, as they want. So there is what we call waivers that they submit requests for, and that anyway. So you can be on Medicare and Medicaid if you're low income disabled or low income senior. You could get both of those programs. What we have out in the field is a grant program called SHIP, State Health Insurance Program, which is kind of like confusing now with the ACA, Affordable Care Act, but that's the name of it, SHIP. And every state has a program. I have a lot of handouts, and I have my presentation on a handout, and I have to apologize. It was collated kind of crazy, so some of the pages are upside down or whatever I'd noticed. But the last page has all the phone numbers for all the state SHIP programs. Every state has its own SHIP program. In Massachusetts, it's called SHINE. And I know their number. It's 1-800-AGE-INFO, because that's an easy one to remember. But New Hampshire has one called Service Link. Connecticut's called Choices. And by the way, these are SHINE and Connecticut are acronyms. So Connecticut's Choices is Connecticut Health Options Insurance Services. I mean, can you believe it? It's actually an acronym. And then in Maine and Vermont and Rhode Island, they're just called the SHIP. We give money to the State Department of Elder Affairs, and they get it out throughout the state. So there will be people, every state is a little different on that too, but usually the area agencies on aging is a prime place where they have SHIP counselors. And what happens when you call them Like, for example, in Massachusetts, I know that they will automatically field the call right to the local area based on where you're calling from. You can talk to them on the phone, or you could sit down and meet with them, whatever you want. And they are not only knowledgeable, very knowledgeable about our program. In Massachusetts, they get 60 hours of training before they start being a counselor, and annual trainings, annual updates. So they're very knowledgeable, but they also are going to know about what might be available in your state too, both in the Medicaid part, and some of the states actually also provide some funding to them, but that is not required, and that's not all the states. They don't all do that. So they'll know more, but there's some other programs out there that they're going to know about. They're going to know also about the local health insurance plans. I work for the Medicare Health Plans area. If you're familiar with the idea of managed care, not everybody is, but that means that we work in the area where a health insurance company comes in and says, I want to service Medicare beneficiaries in Massachusetts only. And we approve it or not approve it or whatever, or they could do Massachusetts and New Hampshire. We have, it could be a national plan. So we have all those kinds of things. And those SHIPs also going to know what's running in their state. So in any given state, there will only be so many health plans. They'll know about them pretty well. It's a great, in fact, they were created when we started offering Medicare through health plans. Congress said we need to add something to help people make their choices if they're going to get a health plan. So that's what they are very helpful on. They're in every state plus District of Columbia, Puerto Rico, Virgin Islands, and Guam. And they are free. So as I said, Massachusetts SHIP is called SHINE, serving health insurance needs of everyone. They have 650 counselors. And by the way, they love that if I give them a plug, they're always looking for new volunteers. And they will train you, and you will really know a lot about Medicare. And what they want in return is your helping others with Medicare. And how you can help can vary. You could be somebody that's willing to sit down one-on-one with people in what we call counseling. You could also do other things. You could be, even helping in the office or other kinds of activities. They need everything. They really rely on their volunteers, as you could see by having 650 of them. They only have like 3 paid staff. So, okay, they've dropped it to 40 hours. It used to be 60. And then they'll train people like at a hospital, different places where people, that individual institution understands the value of getting these people trained so that they can help their own clients or patients. In New Hampshire, it's called Service Link. It's a little bit differently set up in that it is coordinated more tightly with the other programs that are out there. All these programs are available elsewhere, but Service Link in New Hampshire considers itself part of, the SHIP is part of the Service Link, and includes also Aging and Disability Resource Center, which is more about long-term support. And they have a new program called New Hampshire Care Path, which is working with all the other partners out there more closely. Caregiver support and options counseling. Option counseling is about long-term care also. Long-term care, when we talk about that, we're referring to nursing home care, and that is actually usually not a Medicare service. It's going to be a Medicaid service. Medicare won't cover that. So I talked to the local, the Massachusetts director about what to talk about, and she wanted to just point out some challenges that she thought would be useful for people to understand. So there's 4 parts of Medicare, A, B, C, and D. And A is basically hospitalization, but I'm talking room and board. B is your medical costs. So if you see a doctor in the hospital, which you probably will, that could be billed under B. But when you go to a doctor in an office, it's definitely going to be B. And your tests, and some other things to throw in there is mental health, durable medical equipment, which is wheelchairs, oxygen, that kind of stuff. That comes under B. The reason we always talk about it, and actually, I mean, I could talk about Medicare basics for 4 hours. I've done it, okay? It's pretty complicated. But the point is just to say there's a different deductible and there's a different, in terms of understanding why we make the difference. So A, for example, is free, no premium, but it has a big deductible. B has a monthly premium. And 80-20 usually. You have to pay 20%. Preventative services there's not a charge for as a result of the Affordable Care Act. Part C, where I work, and Part D are the two plan areas. So you can get all your Medicare through a health plan, basically. And why would you do that? You look at the costs. You look at maybe that health plan is a private insurance company. They decided that to get some business, they're going to throw in some more benefits. You look at the cost, is it worth that? That's, really, and again, that's what the SHIPs are out there to do. They will help you. They will look at your particular needs and help you make a decision on that. You can change those every year if you don't like what you got. So it's something to consider. And then if you want direct coverage, you have to enroll in direct coverage. And you can get it through a managed care plan. You can get it as a standalone. There's some gaps. Here we have the costs on Part A. As I said, for most people, it's premium free. The only reason it couldn't be premium free is if you're new immigrants. The only time, and I've worked there over 15 years, and the only time I've ever heard of somebody not having a premium is because they were new to the country. Having to pay a premium. You have paid into it in your lifetime. It's not really free. You've already paid for it. It's been taken out of your paycheck, and as long as you have 10 years in your whole lifetime, then you will get it premium free. But the deductible is larger. You get up to 60 days, and then after that, you start to get a copay. Part B does have a monthly premium. Every year, all these numbers go up a little bit every year, but it's just a little bit. So this is the numbers for this year, and then you have a 20% copay for most services. So when you look at that, you say, okay, I think I'm going to need something more than that, okay? And so then people look at how to supplement. You might not, but you want to think about whether or not that's going to be enough for you. And there's two ways to supplement. One is to get a Medicare Advantage plan. That's the Part C plans that will provide additional coverage. And again, you really look at very specifically what does it have that might be of interest that I think I'm going to need or I know I need already. Or you can get a Medigap plan. And that is that could cover some of those costs too. So those are decisions to make. You don't get both. It's illegal for an insurance agent actually to sell you if you have one or the other. But there's no reason for it's duplicative. But it's looking at the specifics. And here's something sort of flagging what the specifics are. Medicare Advantage plans have a whole continuum of managed care options. From the most restrictive being a health maintenance organization, which means you won't get coverage if you go outside the network. But then there's something called a preferred provider organization, which means you can go out, but you're going to pay a little bit more if you go outside the network. I've used PPOs myself a lot, and I found them pretty flexible, pretty workable for me. But and then you want to look at, if you have your own doctor, you want to see if they're in there, in what you have. And a Medicare Advantage could require referrals. You can't just go see a specialist. You have to have the primary care refer you. But why? Again, you might consider it's because they might have extra benefits. Then if you have other insurance you have to look at, again, this is why we have these people in the field. They could sit down and say, okay, I got retiree insurance. Do I need anything else? You may need part of it, you may need not part of it. However, there is a late enrollment penalty if you do not sign up for Medicare when you are out of employment coverage, okay? Not retiree coverage is not going to help with that. So you have 8 months, 7 months after employment coverage ends to enroll in Medicare. You don't have to, but if you don't, you may find that you're going to have a late enrollment penalty when you do, which is added to your premium for the rest of your life. The other thing is I know a lot of employers may say you have to take Medicare as part of your, if you want our retiree coverage, you have to take Medicare. They want Medicare to be covering some of it. We don't ever tell anyone they have to take it, but an employer might. I think a lot of them do now. In addition to, if you're not fully qualified for Medicaid, you don't meet the income and asset requirements, there are other Medicaid programs that pay Medicare costs. There's 4 of them. Again, they vary a little bit by state, but this is low income, but not low income enough to get Medicaid to cover. It will cover your Medicare costs. And then you could have Veterans TRICARE, and now one of those programs requires you to get Part B, Medicare Part B, again. That would be up to that program. So that's another challenge. Another challenge is that Part D, making a choice is how to get, you have a separate late enrollment penalty if you do not get Part D when you're first eligible. That is, but any coverage is going to work for that. So if you have retiree drug coverage, you're going to be okay. You don't have to do it. But if you have VA or TRICARE, you're not going to have it. So again, that penalty is going to be as long as you have the coverage. And the reason, by the way, is that insurance is about risk pool. So we want to incentivize that people get it, whether or not they think they get it, they need it. In the Part D area, when we started with that, it's a standalone plan, and we went out and told people about it, and they kept saying, I don't use any medications, and I'd say, I understand, but you're going to have a late enrollment penalty if you don't get it now. So there's the options are to get it through Medicare, Medicaid Advantage Plan. Medigap policy, actually, the only way you could get that now is if you already have it. You cannot newly get a Medigap policy with drug coverage. Here's some more coverage gaps with the drug benefit. You may have heard about the donut hole, is what we called it. Initial coverage, 75% for the first amount. Then you reach a certain amount in a calendar year, and you will reach a gap in coverage. You will have no coverage. You're still paying the premium. If you get to the catastrophic level, the coverage ups to like 95%. So plan doesn't have to have this. A lot of them do, and it's obviously something that's unusual. We want to be sure people understand this. The Affordable Care Act is closing the gap, but it is. It could mean, and so you could hit the donut hole anytime. You could hit it in January, you could never hit it, you could hit it in December and never get out of the gap. Okay, so I don't have, the numbers might be up there. So the initial coverage limit is $3,750 this year. So once you get to $3,750, you don't get coverage if you have a plan with a donut hole. Then if you reach the catastrophic, which is $7,508, your coverage comes back in. I know it's kind of odd. But that's it. So there are other programs out there that can help. We have a program called Extra Help that can help people, again, of a different income eligibility level than Medicaid. They have a higher income, but they could still get help just with Part D. Veterans Administration has a prescription program. In Massachusetts, there's a program called its Prescription Advantage. Another big deal is that when you're getting on Medicare, if you're 65 and you're on Medicare because of disability, what do you do about the transition? Marketplace and Medicare. If you're on the Affordable Care Act, this is one thing I do want to make sure people understand. If you are in a health insurance exchange in Massachusetts, through the Health Connector, for example, when you get Medicare, you will lose any financial advantage you were getting on the marketplace. Again, we don't tell people what to do, and we do not coordinate that for you. So you may decide that you want to get Medicare, but you need to drop your marketplace because your costs will be very different. You will have the tax credits once you're on Medicare. Marketplace won't disenroll you. People had an assumption that what. and you'll still have that penalty. So you decide to do Marketplace for a while now, and then you want to do Medicare later, you're going to have that penalty on your premium. Open enrollment is every October 15th through December 7th where you can make these changes. Right now, this is getting changed. If you're low income, you could change all the time, but that is getting changed. I also want to make one more point. The phone number for the SHIP program is in the back of the Medicare and You book, which is sent out by September 30th every year to everybody on Medicare. And so it's state specific, and it will say the number of the phone number for the SHIP and the health plans in your state will be listed in the back. That's why it's state specific. And also, one more thing. I know I'm going to get the hook in a minute, but anybody on Medicare now? Do you know you're getting a new Medicare card? Yes. Excellent. Okay. The Social Security number is on your Medicare card now, and so we wanted to take it off forever, but it costs a lot of money. Congress finally gave us the money to do it, and that started this week with people new to Medicare will be getting not the Social Security number based Medicare number. They will get a new randomly generated number. And even if, big message on that is that be sure your address at Social Security is up to date so you get it. And secondly, even if your sister gets it tomorrow, you may not get it for, 2 months. Everybody's going to get them, and we're doing it in waves. So it's not going to go all at once. In other words, it's going to be over a year. And all of our back systems will take both numbers, so we won't hopefully have anybody with a problem with coverage. So that's it. I will be here all day, and if anybody has any questions, please feel free to stop by.